I now recognize Chairman Smith for questions.
Thank you, Chairman Buchanan. When 54% of Medicare beneficiaries are choosing a Medicare Advantage plan, there is clearly a strong and growing interest by seniors to have access to MA and the benefits that come with it, like lower out-of-pocket cost, access to supplemental benefits such as prescription drug coverage and transportation services, as well as specialized plans tailored to patients with chronic conditions. Patient enthusiasm for the program is exactly why we should ensure its integrity. For example, we know of concerns about MA plans inflating a patient's level of sickness, resulting in higher reimbursements for the plan at taxpayer expense, and an estimated $40 billion in 2025 alone. Ms. Maroney, how rampant of an issue is this, and what can Congress do to help support the Trump administration in protecting this program so treatment is given where it is needed?
Excellent question. Full transparency, making sure that organizations, if there is abuse that's going on at an individual organizational level, that organization is being held accountable. Seniors in today's environment, they utilize these programs because they are of value. There's an additional $200 per member per month in benefits that are available and accessible to these individuals, which equates to close to $2,500 or $2,400 a year. And then when you think about if they had to go on Medicare fee-for-service on its own and they're selecting a fee-for-service program, then that program is anywhere from $200 to $300 per member per month, in addition to just to get the full comprehension of the program as a whole. I do believe that there is reform that is required. There's opportunity. There's opportunity for us all to sit at the table and to come up with a collaborative dialogue to make sure that how do we have full transparency and perfection to improve the program but not take away from the program, and to make sure that the individuals that I've talked about, that they're still getting the value of that benefit on a monthly basis, in addition not having to pay hundreds of dollars of premiums when many individuals who are enrolled in these programs are on very fixed incomes. Thank you.
So one of the well-known benefits of engaging the private sector is the faster pace of innovation, which in the case of healthcare means a system that can respond more quickly to the needs of patients and providers. My number one priority when it comes to healthcare reform is expanding access to higher quality care in rural communities. Dr. Bazel, we have seen rapid growth of MA in rural areas in recent years. What are some of the main lessons you've learned from your experience serving rural communities, and how should MA incorporate those lessons to enhance access and deliver better health outcomes for rural patients?
Thank you, Chairman. So one of the potential benefits of being an MA plan is that innovation and that flexibility to be able to respond to the needs, especially in our rural areas, our community health needs assessments that the hospitals do every couple of years. Transportation is a good example of something that comes up in the top 2 or 3 needs in those assessments in every one of our communities. Especially in our rural areas, there are not such things as ride-sharing programs or even taxi services. And a lot of times, our hospitals are where that ends up taking on both the medical transportation, but even the non-medical transportation, getting someone to social activities. Loneliness, social isolation is one of the biggest predictors of adverse health in the elderly. And so that's a good example of where it's worth it to us, to look at that transportation and to bear some of the cost of developing those programs, even though that's not a traditional healthcare expense. And so it's that type of innovation that the promise of MA hopefully can deliver on.
Thank you. In addition to the upcoding issues, we have heard about the MA plans, excessive pre-approvals can get in the way of timely care for patients and layer on additional paperwork for providers. In our rural communities, 80% of providers say utilization management creates administrative burdens. Dr. Miller, can you shed some light on how practices like excessive prior authorization have become a growing problem, and what can be done to improve care for patients and reduce burdens on providers while still maintaining the goal of a more efficient, lower-cost healthcare system?
I think everyone has a stake in this one. First of all, it should be one-click submission of data in the electronic health record. The patient's seeing you, you shouldn't get a request weeks or months later. It should be real time. You submit your data, it automatically ports labs, notes, imaging studies. You should be able to access what the medical criteria are. For outpatient prescription drugs, for example, you should know whether it's non-formulary, tier 1, tier 2, tier 3. So pushing that information to the point of care is something that CMS and plans can do together. I think on the provider side, we need to improve our documentation enormously. So a lot of denials are because you don't have the right information, you don't have the member number, you don't have the date of birth. The note is copy forwarded for every single day of the 24-day hospitalization and says the exact same thing with no additions. A lot of tools that we can do to support doctors and hospitals with documentation, the ambient AI scribes, the voice dictation. I think a lot of those things that will happen over the next 5 years from both the hospital industry, the plan industry, and CMS as a regulator can actually solve a lot of these problems. It's very fixable.
Thank you. Thank you, Chairman Buchanan. Chairman Schweikert, I yield back.